Good evening. Am I audible? If I'm audible, can I get a confirmation on the chat, please? Am I audible, all of you? Can I see a confirmation in the chat box so that... Good evening, Ayush. Thank you, Ragul, Manasa. So, if you're joining the session for the first time, this is Dr Shanmugapriya. I'm professor and head of the Department of Biochemistry at Government Thoothukudi Medical College, and I'm your Unacademy educator for Biochemistry. And as you all know, today's session is on adrenal cortex and congenital adrenal hyperplasias. And I chose this topic because in the recent both INI-CT and in FMG there was a question on congenital adrenal hyperplasia, and many students made a mistake in those questions. So I thought I will help you understand the concepts behind adrenal cortex and congenital adrenal hyperplasia. So that's the plan for today's session. And before we start the session, let me tell you a few facts about Unacademy plans. Plus subscription gives you an access to both live and recorded classes. It also gives you an access to a question bank with 25,000 plus high yield clinical case based MCQs. Iconic subscription gives you an access to both Unacademy and Preplada platform. Special class features include interactive live sessions. You will be able to participate in polls, and if you use the raise a hand option, you will be able to interact with the educator one-on-one, and you can get your doubts clarified real time. And these are our toppers in the latest NEET PG September 2021. The highest was 694, closely followed by 688. Yeah, both of which are impressive. And this is about our weekly test ritual that's happening regularly on Unacademy platform. We have both free test rituals and plus batch test rituals. So I strongly recommend that you take up as many tests as possible depending upon what topic you're working. I would like to recommend this to you all, particularly the Study With Me YouTube test series. Yeah, so as you know, there are 4 sessions starting from Monday, that's yesterday till Thursday. We'll be having 4 sessions, followed by this on Friday at 9 p.m. You'll be having a test purely based on the topics that are being discussed on the 4 days. Okay, so try to attend all these sessions, get the PDF from my Telegram group, revise those PDFs, and then try to attend. That will give you more confidence. And after that, if you have any doubts, good evening, Tireless. So after that, if you have any doubts, you can just check with me on Telegram group. Okay. And we have structured batches for all upcoming exams. We have Focus FMG 2022 Comprehensive Batch and Target NEET PG 2022 MCQ Discussion Batch. And this is an impressive module that has been put forth for you all if you are a NEET PG 2022 aspirant. It has got 2 modules. The first one is an MCQ discussion module, and the second one will be an ultra fast revision when you will be taught about all previous year questions. And this is about the NEET PG subscription plan, and the minimum that you can subscribe for is 3 months subscription, which would cost you 11,250. But if you use any of the educators code, you will get an additional 10% off. And my code is Biochem Live. So you can use Biochem Live to get a 10% off for NEET PG subscription plans. Okay. So that's all about Unacademy plans. Let's now start discussing few MCQs. Using these MCQs, I'll help you exactly understand about adrenal cortex and congenital adrenal hyperplasia. So the first question is Zona reticularis secretes what? Can you all try answering in the chat box? Yeah, Zona reticularis secretes what? Does it secrete aldosterone or cortisol or androstenedione or dihydroxytestosterone? Ragul J thinks it's dihydroxytestosterone. Janet thinks it's androstenedione. Ayush thinks it's aldosterone. Okay, so there is equal number of competition between androstenedione and dihydroxytestosterone. Answer is androstenedione. Yeah, Zona reticularis secretes androstenedione. So I know you all know that there are 3 zones in adrenal cortex. What are the 3 zones, all of you? The 3 zones are zona glomerulosa, fasciculata and reticularis. And of the 3 zones, what does glomerulosa secrete? Glomerulosa, as the name indicates, has got something to do with glomeruli, right? So it secretes a mineralocorticoid aldosterone. Is that clear, Ayush? Yes. So glomerulosa secretes aldosterone. Fasciculata secretes a glucocorticoid cortisol. And reticularis secretes a sex steroid androstenedione. Yeah, what is released from adrenal cortex? It is androstenedione, which then gets converted to testosterone. That then becomes dihydroxytestosterone, and that is the most potent androgen. And dihydroxytestosterone formation is done by 5-alpha reductase, and 5-alpha reductase activity is found only in gonads and in skin. Yeah, it is found only in gonads and skin. So adrenal cortex cannot synthesize dihydroxytestosterone. What does it synthesize, all of you? It synthesizes androstenedione. Clear? So it's a very simple question. Reticularis secretes androstenedione. So the next question is the region which does not undergo atrophy following hypophysectomy is following pituitary removal. Yeah, you know pituitary releases ACTH, and ACTH stimulates adrenal cortical cells. So following pituitary removal, which of the following zones do not undergo immediate atrophy? Can you try answering? Good, Janet. Tireless, both of you are right. It is zona glomerulosa. Yeah, it is zona glomerulosa which does not undergo immediate atrophy. It is not C, all of you, it is A. Okay, reason is, so few facts about ACTH. You know ACTH stimulates all 3 zones, glomerulosa, fasciculata and reticularis. So it stimulates the release of all 3 steroid hormones, aldosterone, cortisol and sex steroids. All these synthesis will be stimulated by ACTH. Okay, but ACTH in a feedback mechanism is inhibited only by the glucocorticoid cortisol. Though it stimulates aldosterone, cortisol and sex steroid synthesis, in a feedback mechanism it is inhibited only by the glucocorticoid cortisol. Now another fact that I want you all to understand is, when all zones are dependent only on ACTH for getting stimulated, yeah, when all zones are dependent on only ACTH for getting stimulated, one exception is glomerulosa. Because glomerulosa is not only stimulated by ACTH, it is also stimulated by angiotensin 2. Don't we know that? Renin angiotensin aldosterone system. So angiotensin 2 stimulates glomerulosa to release aldosterone. And not only angiotensin 2, even hyperkalemia can stimulate glomerulosa. Don't we know that? Because what does hyperkalemia do? It stimulates aldosterone secretion, and this aldosterone causes potassium secretion. Yeah, it causes potassium secretion. So tell me about glomerulosa. Glomerulosa is a zone that is stimulated by 3 stimuli. What are the 3 stimuli? One is, as always, ACTH. The second one is angiotensin 2. Yeah, second one is angiotensin 2, and the third one is hyperkalemia. That is why following hypophysectomy, when there is no ACTH, glomerulosa will not undergo immediate atrophy, because for some time it will be kept stimulated by angiotensin 2 and hyperkalemia. Is that clear? So which zone does not undergo immediate atrophy following hypophysectomy, all of you? Yeah, it is glomerulosa. Clear? So the next question is also about glomerulosa. It's something interesting about glomerulosa. A case of adrenal hyperplasia suggested adrenalectomy. Okay, the surgeon would leave back a segment of which of the following zones during adrenalectomy, adrenal corticalectomy? Which zone will be left back? Very good, TS. Anyone else? Whenever adrenal corticalectomy is done, yeah, whenever adrenal corticalectomy is done, we always leave back a segment of zona glomerulosa. Very good. We always leave back a segment of zona glomerulosa, because glomerulosa has got stem cell like property. Yeah, it has got stem cell like property. Given an adequate stimulus, glomerulosa can differentiate into either a cell of its own kind, or into fasciculata type, or into reticularis type. And that is why whenever adrenal corticalectomy is done, which zone is left back? A part of glomerulosa is left back in an attempt to replenish the other 2 zones. Okay. All the following are properties of ACTH except. Does it have diurnal variation? I will give you 30 seconds time to give me the answer. Does it have diurnal variation? Does it increase the adrenal responsiveness? Does it exhibit a ceiling effect? Continuous stimulation of aldosterone secretion. What is the right answer, all of you? All of the following are true except. Duri Ravi Shankar thinks it's D. Tireless also thinks it's D. Very good, all of you. All of you are right. The answer is this. Yeah, so ACTH does not stimulate aldosterone secretion continuously. It can only do it transiently. Yeah, ACTH can stimulate aldosterone secretion only transiently. So let me tell you all facts related to ACTH. I want you to listen to this carefully because this is the basis of you understanding all clinical conditions related to adrenal cortex. Okay. So listen to this. The first fact about ACTH is, as you all know, it exhibits diurnal variation. We know it is maximally secreted around 6 a.m. Don't we know that? It is maximally secreted around 6 a.m. Reason is CRH, corticotropin releasing hormone, is maximally released around 6. Accordingly, ACTH is released maximally around 6, and that is why cortisol secretion is also maximum around 6 a.m. So all these hormones exhibit a diurnal variation. Second one is it increases the adrenal responsiveness, or in other words, ACTH has got an ability to sensitize adrenal cortical cells. Do you all understand this? ACTH has got an ability to sensitize adrenal cortical cells. So ACTH will be able to act on an adrenal cortical cell which is already sensitized. And that is why what happens in a person who is on exogenous glucocorticoid. Yeah, sorry. I think I made it. I pressed end. One second. Yeah. So what was I telling you? It increases adrenal responsiveness. That is why what happens when a person is on exogenous glucocorticoid. This exogenous glucocorticoid, you know, very good, tireless, it suppresses ACTH. And when there is no ACTH, what will happen to adrenal cortical cell? It will get desensitized. And in this scenario, if you suddenly withdraw exogenous glucocorticoid, what will happen? The moment you withdraw exogenous glucocorticoid, immediately ACTH secretion will begin. Yeah, immediately ACTH secretion will begin. But this ACTH goes and strikes an adrenal cortical cell which is desensitized. So will it be able to immediately release cortisol? No. And that is why there is going to be a period of hypocortisolism if you suddenly withdraw exogenous glucocorticoid. So to avoid hypocortisolism, what are you supposed to do? You are supposed to taper the dose of exogenous glucocorticoid. When you slowly withdraw exogenous glucocorticoid, as and when you decrease the dose of exogenous glucocorticoid, slowly ACTH secretion begins. And this ACTH will slowly sensitize the adrenal cortical cell. And in this scenario, if you completely withdraw exogenous glucocorticoid, ACTH is striking an adrenal cortical cell which has been already sensitized. So immediately there will be cortisol secretion. And that is why what are you supposed to do? Very good, right. That is why what are you supposed to do? You are supposed to only taper the dose of exogenous glucocorticoid. Reason is ACTH sensitizes adrenal cortical cells to its own stimulation, and it will be able to act only on an adrenal cortical cell which has been already sensitized. Okay, so that's the second fact. Now the third fact is it has got a ceiling effect. What do you mean by a ceiling effect? If you draw a graph, with ACTH level along x-axis and cortisol level along y-axis. As you increase ACTH concentration in the blood, only initially there will be a corresponding increase in cortisol level. Beyond a point, even if you increase ACTH, cortisol secretion cannot be stimulated any further. And this is what we mean by ceiling effect. So what are the three facts I told you about ACTH? Diurnal variation, it increases adrenal responsiveness, and number 3 is it has got ceiling effect. And the fourth fact I've already told you, though ACTH stimulates all three steroid hormone synthesis, ACTH is inhibited in a feedback mechanism only by the glucocorticoid cortisol. I told you, right? Though it stimulates the synthesis of all steroid hormone, it is inhibited in a feedback mechanism only by the glucocorticoid cortisol. And the last fact is something which is clinically relevant. Listen to this. As I told you, ACTH stimulation of aldosterone secretion is only transient. Yeah, ACTH stimulation of aldosterone secretion is only transient. So I am going to tell you about a clinical condition called as glucocorticoid remediable hyperaldosteronism. Okay, I am going to discuss about a condition. Have you heard of this condition, all of you? No, listen to this, Ayush, you will understand it by the end. So have you heard of glucocorticoid remediable hyperaldosteronism? We'll be discussing about that now. Okay, so ACTH stimulation of aldosterone secretion is only transient. Reason is, can you all type in the chat box which enzyme synthesizes aldosterone? Which enzyme synthesizes aldosterone? Give a logical name to an enzyme which synthesizes aldosterone. Aldosterone synthase. Yeah, the enzyme which synthesizes aldosterone is aldosterone synthase. And this aldosterone synthase has got a regulatory region. And that regulatory region responds to ACTH only transiently. Yeah, it can that is why dotted lines. Dotted lines to tell you that it's only a transient stimulation by ACTH. Whereas what is the enzyme which synthesizes glucocorticoid? What is the enzyme which synthesizes glucocorticoid? It is not glucocorticoid synthase. It is 11-beta hydroxylase. So I will ask you this when we discuss about congenital adrenal hyperplasia. Memorize this. Which enzyme synthesizes glucocorticoid? It is 11-beta hydroxylase. And this 11-beta hydroxylase has got a regulatory region. And that regulatory region responds to ACTH continuously. Okay, but interestingly, the genes of these two enzymes, the genes of these two enzymes are present closely in chromosome 8. They are present closely in chromosome 8, that many cases have been reported with unequal crossover. Yeah, with unequal crossover of regulatory region of 11-beta hydroxylase with that of aldosterone synthase. Yeah, regulatory region of 11-beta hydroxylase gets paired with that of aldosterone synthase. In that case, tell me what will happen. Now, aldosterone synthase will start responding to ACTH continuously. I told you, right? Dotted line means transient stimulation. Continuous line is to denote sustained stimulation. So, now aldosterone synthase will be sustained, will be stimulated by ACTH in a sustained manner. And continuously what will be produced? Aldosterone will be produced. But didn't I tell you aldosterone cannot inhibit ACTH? I told you, right? ACTH is inhibited only by what? It is inhibited only by the glucocorticoid cortisol. So aldosterone cannot inhibit ACTH. So this sets up a vicious cycle. Continuously ACTH stimulates aldosterone production. Aldosterone is produced and that causes hyperaldosteronism. Yeah, it causes what? Hyperaldosteronism. So tell me, what is the clinical feature of hyperaldosteronism always? All of you? What do you expect in hyperaldosteronism? It causes sodium reabsorption, right? When sodium gets reabsorbed, along with that water gets reabsorbed. So that causes hypertension and hypernatremia. And it causes potassium secretion. So there will be hypokalemia. Very good. Yes, Nurul. Good. So hypernatremia and hypokalemia will be the manifestation of hyperaldosteronism. Now, how will you treat this hyperaldosteronism? What should you suppress to treat this hyperaldosteronism? You should suppress this ACTH. How can you suppress this ACTH? By giving, how can you suppress this ACTH, all of you? By giving exogenous glucocorticoid. Yeah, by giving exogenous glucocorticoid. In that case, can you call it as glucocorticoid remediable hyperaldosteronism, all of you? Can you call it as glucocorticoid remediable hyperaldosteronism? So what are the facts that you need to know about glucocorticoid remediable hyperaldosteronism? The first fact is it's an autosomal dominant condition. Yeah, it is an autosomal dominant condition wherein there is unequal crossover of regulatory region of 11 beta hydroxylase with that of aldosterone synthase. So aldosterone synthase starts responding to ACTH continuously. Continuously aldosterone is produced, that causes hyperaldosteronism. And to treat the hyperaldosteronism, you will have to give exogenous glucocorticoid, and that's called as glucocorticoid remediable hyperaldosteronism. So when will you suspect this condition? Yeah, when will you suspect this condition? Suppose a small boy, 10 to 15-year-old boy is presenting with intractable hypertension. Yeah, the person comes and complains of headache, and then you are randomly checking the blood pressure, you find it to be very high. And you are trying to treat this hypertension, you are giving regular drugs, the person does not respond to any of those regular drugs. That's why I call it as intractable hypertension, refractory hypertension. But if you start cortisol, if you give glucocorticoid, there will be a quick response. In that case, what will be your suspicion? Your suspicion should be glucocorticoid remediable hyperaldosteronism. And if you estimate sodium levels and potassium levels, there will be hypernatremia and hypokalemia. Aldosterone level will be high, and it is confirmed. It is confirmed only by genetic testing. Yeah, genetic testing will show you this hybrid gene. The crossover gene product can be detected by genetic testing. Is that clear? So that's about glucocorticoid remediable hyperaldosteronism. So this is a summary of properties of ACTH. If you understand these properties of ACTH, you will be able to understand all about glucocorticoid remediable hyperaldosteronism and about congenital adrenal hyperplasias. Okay. Won't there be features of low cortisol in such a patient? No, because it is responding to ACTH transiently, right? So transiently it stimulates and transiently cortisol is produced. Also, many aldosterone intermediates have glucocorticoid actions. I will show you the step of synthesis of glucocorticoid. Steps of synthesis of aldosterone. You will find out that many of the intermediates have glucocorticoid actions. So you won't find any features of hypocortisolism. That's a good question, Ayush. Okay, so now answer this question. All the following are properties of ACTH except. Will there be diurnal variation? Can you all type it as true or false? True, diurnal variation maximum around 6 a.m. Does it increase adrenal responsiveness? True. That is why you are not supposed to, that is why you are not supposed to suddenly withdraw exogenous glucocorticoid. Ceiling effect? True. Continuous stimulation of aldosterone secretion. Continuous stimulation of aldosterone secretion is false, because normally it's only a transient stimulation of aldosterone secretion. When it becomes continuous, that is what we call as glucocorticoid remediable. Very good, Nurul. That is what we call as glucocorticoid remediable hyperaldosteronism. So read this question. A 10-year-old boy presented with intractable headache. His blood pressure was high. He was started on amlodipine, and as there was no little or no response, he was put on amlodipine clonidine combination. A second physician started prednisolone, and there was a quick response. The physician checked. Very good. Good. So the physician checked and detected a chimeric gene mutation. I told you, right, on chromosome 8. This is the confirmatory test for glucocorticoid remediable hyperaldosteronism. So answer is this. Okay. The most common congenital adrenal hyperplasia is deficiency of. I am sure you all know the answer for this question. The most common congenital adrenal hyperplasia is deficiency of. In glucocorticoid remediable Duri Ravishankar, I just now gave the answer to Ayush. Endogenous cortisol secretion will happen normally, because there is transient stimulation, and the intermediates of aldosterone are all glucocorticoids. Good. So there is only one person who has answered it as B. TS alone has answered it as B. TS, remember, it is 21 beta hydroxylase, which is the most common type of congenital adrenal hyperplasia. Okay, so because it is the most common type, let me tell you few facts about it. 21 beta hydroxylase deficiency will present a salt wasting form. So how do we remember it as a salt wasting form? It is 21, right? 2 has wasted 1 and has become 1. Yeah, that is how I remember it. 2 has wasted 1 and has become 1. So 21 beta hydroxylase will present as what? It will present as salt wasting form of congenital adrenal hyperplasia. And it will also present with female pseudo hermaphroditism. Yeah, it will also present with, what do you mean by female pseudo hermaphroditism? A person with XX chromosome showing virilization. Yeah, person with XX chromosome showing virilization. And female pseudo hermaphroditism is quite common because a female can remain a female only until the female is specified with an androgen. Exposure to androgen in any form will cause virilization. So female pseudohermaphroditism is quite common when compared to male pseudohermaphroditism. Is that clear? So what is that you know about congenital adrenal hyperplasia? The most common type will be 21 beta hydroxylase defect. 2 has wasted, 1 has become 1. So it presents a salt wasting form of congenital adrenal hyperplasia, and it will present with female pseudohermaphroditism. And there is one other condition which resembles 21 beta hydroxylase deficiency closely, and that is 3 beta hydroxysteroid dehydrogenase defect. So all of you please remember, both 21 beta hydroxylase defect and 3 beta hydroxysteroid dehydrogenase defect will present a salt wasting form with female pseudohermaphroditism. And there is only one congenital adrenal hyperplasia which presents as male pseudohermaphroditism. I told you, right, female pseudohermaphroditism is common. The only one condition which presents as male pseudohermaphroditism is 17 alpha hydroxylase deficiency. So for now, all of you memorize these facts. In another 5 minutes, I will be telling you why for all these. Yeah, because I don't believe in just memorizing facts. Yeah, memorizing fact will be step number 1, but you will have to understand the concept and then memorize facts and then have both in association, so that even when one of those two fail you during examination, the other will help you. Okay, so which congenital adrenal hyperplasia will present as male pseudohermaphroditism, all of you? It is 17 alpha hydroxylase deficiency. Okay, and if I tell you that these two conditions present a salt wasting form, so what are the conditions which will present as hypertensive forms? Yeah, what is left out? Hypertensive forms will be 11 beta hydroxylase deficiency and 17 alpha hydroxylase deficiency. Is that clear? Hypertensive forms will be 11 beta hydroxylase and 17 alpha hydroxylase deficiency. So 17 alpha hydroxylase belongs to both the exceptions. Yeah, 17 alpha hydroxylase deficiency will belong to both the exceptions. It will present as male pseudohermaphroditism and as hypertensive forms. Okay. So that's about this question. So I've told you all these. Yeah, the most common type is 21 beta. And 21 beta presents a salt wasting form with female pseudohermaphroditism. The other condition which closely resembles that is 3 beta hydroxysteroid dehydrogenase deficiency. And the only one condition which presents as male pseudohermaphroditism is 17 alpha hydroxylase deficiency. Hypertensive forms will include 11 beta hydroxylase and 17 alpha hydroxylase defect. Okay. Okay, so this is, this is an FMG question. You won't believe it. Yeah, I was not able to believe that it was an FMG question. It's quite complicated. Listen to this, try to answer this. A 2-month-old boy presented with ambiguous genitalia. Yeah, so male pseudohermaphroditism. What will be your answer, all of you? Male pseudohermaphroditism. What will be your answer? Yes, 17 alpha hydroxylase deficiency. The answer is going to be 17 alpha hydroxylase deficiency. So now I'm going to tell you why for all these facts. Okay. So you know that all these three steroid hormones, aldosterone, cortisol and sex steroids, they are all synthesized from a common precursor, which is cholesterol. Right? It is all synthesized from a common precursor, cholesterol. So listen to this carefully. By the end of this discussion, I will be telling you why some steroids are called a C21, why some are called a C19 and why some are called a C18. And by the end of this discussion, you will have a mental algorithm to clearly diagnose any of the congenital adrenal hyperplasias. Okay. So you have started with cholesterol, and this cholesterol has got 27 carbon atoms. It has got how many carbon atoms? 27 carbon atoms. So cholesterol is called as a C27 steroid. Have you understood this? It's called a C27 steroid. And it is acted upon by the first enzyme, which is desmolase. Yeah, cholesterol desmolase. And this cholesterol desmolase removes 6 carbon atoms. Yeah, it removes 6 carbon atoms from cholesterol, converting cholesterol to pregnenolone. Converting cholesterol to pregnenolone. So can you all tell me what kind of steroid is this pregnenolone? From 27, if you remove 6 carbon atoms, I will tell you about that, Vivek, now. Yes, BP can be normal or high. Only when it is salt wasting form, you can think of other hyperplasias. In hypertensive forms, when I say hypertension, it will not immediately present as hypertension. Yes. So pregnenolone will be called as C21 steroid. Okay, pregnenolone is a C21 steroid. And this pregnenolone is acted upon by the next enzyme. The next enzyme is the notorious enzyme known for its exceptions. So what is the next enzyme? It is 17-alpha hydroxylase, which converts pregnenolone to 17-hydroxypregnenolone. And then 1720 lyase, yeah, 1720 lyase converts 17-hydroxypregnenolone to a weak androgen, which is DHEA. It forms a weak androgen, which is DHEA. And this 1720 lyase removes 2 carbon atoms. So from C21, if you remove 2 carbon atoms, what will you call DHEA as? From 21, you have removed 2. So DHEA is a C19 steroid. Yeah, it is a C19 steroid. And that is why DHEA, androstenedione, testosterone, dihydroxytestosterone, all male sex hormones. Yeah, DHEA, androstenedione, testosterone, dihydroxytestosterone, all these 4 being male sex hormones, they are all C19 steroids. Clear? Now, how will you convert these androgens to estrogen, all of you? How do we convert androgen to estrogen? Can I see the answer in the chat box? By the action of aromatase. So aromatase removes 1 carbon atom, converting androgen to estrogen. So what are the estrogens? Estrone, estradiol, estriol. Yeah, estrone, estradiol, estriol. They are all C18 steroids. Now how about the remaining? Very good Crusader, Ravi Shankar, Vijay Lakshmi, excellent. So how about other steroid hormones? What are the other steroid hormones? You have your mineralocorticoid aldosterone. You have your glucocorticoid cortisol and progesterone. Yeah, so aldosterone, cortisol, progesterone, all these are derivatives of pregnenolone. So they're all C21 steroids. Is that clear? They're all C21 steroids. So have you understood this? Please don't forget this anytime. Androgens, DHEA, androstenedione, testosterone, dihydroxytestosterone or C19 steroids. Female sex hormones, estrogens, yeah, estrone, estradiol, estriol or C18 steroids. Aldosterone, cortisol, progesterone or C21 steroids. Okay. So let's get back to steroid hormone synthesis. For now, what we have discussed is this: pregnenolone, 17-hydroxypregnenolone and DHEA. Now, all these 3 will be acted upon by the next enzyme. The next enzyme is 3-beta-hydroxysteroid dehydrogenase. Didn't I tell you about this enzyme? 3-beta-hydroxysteroid dehydrogenase and 21-beta-hydroxylase defect are very similar. Okay. So the next enzyme is 3-beta-hydroxysteroid dehydrogenase, which converts pregnenolone, 17-hydroxypregnenolone and DHEA to form progesterone. 17-hydroxypregnenolone becomes 17-hydroxyprogesterone. DHEA becomes androstenedione. And what did I tell you is the function of Yes, and what did I tell you about, what did I tell you is the function of zona reticularis? It is to release androstenedione. And I want you to understand this androstenedione is not only formed through this route. Yeah, it is not only formed through this route. You can also form androstenedione from progesterone getting converted to 17-hydroxyprogesterone, by which enzyme 17-alpha hydroxylase, and 17-hydroxyprogesterone in the presence of 17-20 lyase can also form androstenedione. Is that clear? So through two routes you can form androstenedione. And once you are done with synthesizing androstenedione, function in reticularis is over. Do you all understand this? Function in reticularis is over. Now what happens in glomerulosa and fasciculata? In glomerulosa and fasciculata, the next enzyme is the most common defect. What is the most common defect? 21 beta hydroxylase. So that converts progesterone and 17-hydroxyprogesterone to form 11-deoxycorticosterone and 11-deoxycortisol. Now the same story, you can also convert 11-deoxycorticosterone to 11-deoxycortisol by the same 17-alpha hydroxylase. So 17-alpha hydroxylase catalyzes all these steps. Do you understand this? It catalyzes all these steps. Now till the steps involved in glomerulosa and fasciculata are the same. Till you form 11-deoxycorticosterone and 11-deoxycortisol, activity in glomerulosa and fasciculata are the same. From now it's going to be different. What should a glomerulosa synthesize, all of you? What should a glomerulosa synthesize? It should synthesize aldosterone. And what did I tell you is the enzyme which synthesizes aldosterone? It is aldosterone synthase. So if it is glomerulosa, the next enzyme is aldosterone synthase, which converts 11-deoxycorticosterone to aldosterone. Okay, this is about glomerulosa. If it's fasciculata, what should it synthesize? It should synthesize glucocorticoid. And what did I tell you is the enzyme which synthesizes glucocorticoid? Glucocorticoid is synthesized by 11-beta hydroxylase. So in fasciculata, the next enzyme is 11-beta hydroxylase, which converts 11-deoxycorticosterone to corticosterone, and it converts 11-deoxycortisol to cortisol. Okay, so have you completed the synthesis of all steroid hormones? Your aim is to synthesize aldosterone, cortisol, androstenedione and progesterone. Okay, so this is about the steps which happen in adrenal cortex. Is it clear? Yeah, is it clear, all of you? Okay, so can we start discussing what happens when there is enzyme defect? I will be sharing the PDF in the Telegram group. So in the Telegram group, you can download the PDF and you can start revising. Okay. So let's start discussing what happens when these enzymes are defective. Let me tell you what happens when the first enzyme cholesterol desmolase is defective. When cholesterol desmolase is defective, don't you see that even pregnin alone, a precursor of progesterone which is necessary for continuation of pregnancy, is not being synthesized. When cholesterol desmolase is defective, even pregnin alone, a precursor of progesterone which is necessary for continuation of pregnancy, cannot be synthesized by the fetus. So it will present as death in utero. Yeah, it will present as death in utero. That is why among the choices I did not include cholesterol desmolase defect at all, because it is not, it is going to present as death in utero. Okay. Now what happens when the next enzyme 3-beta hydroxysteroid dehydrogenase is defective? When 3-beta hydroxysteroid dehydrogenase is defective, all of you tell me, can you synthesize aldosterone? Tell me quickly. You cannot synthesize aldosterone, you cannot synthesize cortisol. When there is no aldosterone, can you reabsorb salt? You cannot reabsorb salt. So what will it cause? It will cause salt wasting. Yeah, it will cause salt wasting. That is why, what did I tell you? 3-beta hydroxysteroid dehydrogenase deficiency will present as salt wasting form. And when there is no cortisol, will there be feedback stimulation of ACTH? I was repeatedly telling you, low ACTH, or when there is high ACTH, it inhibits when there is high cortisol, it inhibits ACTH. Now that there is low cortisol, it stimulates ACTH, and this ACTH will stimulate all adrenal cortical cells to undergo hyperplasia. So what will you find? You will find congenital adrenal hyperplasia. So it will present as salt wasting form of congenital adrenal hyperplasia. And when ACTH stimulates adrenal cortical cells, it stimulates adrenal cortical cells to take up excess cholesterol. And the excess cholesterol will be diverted towards forming what? The block is here, right? You have blocked it here. So when you have blocked it here, what will be formed? It is going to form excess DHEA. And what did I tell you about excess DHEA? DHEA is an androgen. It's a weak androgen. So if it's a female fetus, the female fetus is getting exposed to androgen in excess. And that causes virilization. And that is why I told you it will present as female pseudo-hermaphroditism. Do you all understand this? That is why it will present as female pseudo-hermaphroditism. What will happen if it's a male fetus? In a male fetus, there is production of only DHEA. Even androstenedione is missing. No testosterone, no dihydroxytestosterone. And you must have all learnt that dihydroxytestosterone is essential for establishing male type of external genitalia. So when there is no dihydroxytestosterone formation in a male fetus, external genitalia will not be developed properly. So it will present with external genitalial defects like hypospadiasis. Yeah, what will it present as? It will present as hypospadiasis. So all of you tell me what you expect whenever there is 3-beta-hydroxysteroid. Okay, neural precocious puberty is observed only when there is excess androsterone, only when there is excess testosterone and excess dihydroxytestosterone. In this case, even androstenedione is not formed. So it presents as hypospadiasis. So have you all understood this? Yeah. So what is the first condition I've told you about? I've told you about 3-beta-hydroxysteroid dehydrogenase defect. And what will it present as? It will present a salt wasting form because there is no aldosterone. Congenital adrenal hyperplasia because there is no cortisol, which causes feedback stimulation of ACTH and adrenal hyperplasia. And it will present as female pseudo-hermaphroditism because the excess cholesterol that is taken up by adrenal cortical cell will be forming DHEA. And if it's a male fetus, it will cause hypospadiasis or some external genitalial defects. Okay. Now what happens when the next enzyme, what is the next enzyme? 21-beta-hydroxylase. So now I will expect you to answer this. When there is 21-beta-hydroxylase defect, again what is not formed? No aldosterone and no cortisol. When there is no aldosterone, sodium cannot be reabsorbed. So again it will present a salt wasting form. When there is no cortisol, feedback stimulation of ACTH will cause adrenal hyperplasia. So it will present a salt wasting form of congenital adrenal hyperplasia. Okay, and it stimulates adrenal cortical cells to take up excess cholesterol. Will not, what is your doubt? 3-beta deficiency, yes. Will not there be female external genitalia even in a male fetus? No, because there is DHEA formation, to some extent male type external genitalia gets established, just that it is not proper. Androstenedione cannot be formed by other pathway. All pathways will be needing the same enzyme tireless. Wherever it's happening, be it adrenal cortex or in gonads, it's going to need the same enzyme. So when the enzyme is defective, everywhere it's going to be defective. Okay. Yes. So when there is 21-beta-hydroxylase defect, I told you there is congenital adrenal hyperplasia and the excess cholesterol that is taken up. Yeah, the excess cholesterol that is taken up will be diverted towards forming what? DHEA first, and that then gets converted to androstenedione. That becomes testosterone and that becomes dihydroxytestosterone. There is no block here. So excess dihydroxytestosterone, what happens in a female fetus? Very good. It causes again female pseudo-hermaphroditism. Have you all understood this? It causes female pseudo-hermaphroditism. What will happen in a male fetus? The male fetus is getting exposed to androgen in excess well in advance. Do you all understand this? The male fetus is getting exposed to androgen in excess well in advance. So male, it will present as male precocious pseudo-puberty. Very good, all of you. Neural, it is not precocious puberty, it is precocious pseudo-puberty. Pseudo because there is no gametogenesis. Yeah, there is no gametogenesis. There is only secondary sexual characteristics establishment. So it is pseudo-puberty. Do you all understand this? It causes male precocious pseudo-puberty. So have you all understood this clearly? Yeah. So what have you understood it now? You have understood that both 3-beta hydroxysteroid dehydrogenase defect and 21-beta hydroxylase defect will present with salt wasting form of congenital adrenal hyperplasia with female pseudo-hermaphroditism. The difference is observed only in male fetuses. In 3-beta hydroxysteroid dehydrogenase defect, in a male fetus you find it as hypospadiasis. In 21-beta hydroxylase defect, it will present as male precocious pseudo-puberty. So it is indistinguishable clinically. DHEA to androstenedione and 3-beta hydroxysteroid. No, how can it form? It's the only way. The only enzyme which can convert DHEA to androstenedione is 3-beta hydroxysteroid dehydrogenase defect. Okay, so it is indistinguishable. Both these conditions, 3-beta hydroxysteroid dehydrogenase defect and 21-beta hydroxylase defect, both these conditions are indistinguishable clinically. Okay, so how do you differentiate the two conditions? It is done biochemically by estimating 17-hydroxyprogesterone. Do you see a purple color box that I have shown you here? Yeah, so what do you estimate to differentiate these two conditions? We estimate 17-hydroxyprogesterone. Ayush, I want you all to understand that 1720 lyase is an enzymatic activity that is exhibited by 17-alpha hydroxylase. Is that clear? Both these are catalyzed by the same enzyme. I have just given you the enzymatic activity. It is completely 17-alpha hydroxylase. Okay. So what do you estimate to differentiate the two conditions? You estimate 17-hydroxyprogesterone. If 17-hydroxyprogesterone is high, what is your diagnosis? If 17-hydroxyprogesterone is high, it is 21-beta hydroxylase defect. Okay, it is. Have you all understood this? Please understand that these two are the same enzymes. Okay. So you estimate 17-hydroxyprogesterone. When 17-hydroxyprogesterone level is elevated, it is 21-beta hydroxylase defect. If 17-hydroxyprogesterone level is low, it is 3-beta hydroxysteroid dehydrogenase defect. Okay, so that's about these two conditions. Now let's try to discuss what happens when there is 11-beta hydroxylase deficiency. When there is 11-beta hydroxylase deficiency, tell me, is cortisol getting synthesized in any way? No. So there is no cortisol. This causes feedback stimulation of ACTH. And ACTH will stimulate adrenal cortical cells that causes congenital adrenal hyperplasia. And it stimulates adrenal cortical cells to take up excess cholesterol. When the excess cholesterol is taken up, it is diverted towards forming what? It is diverted towards forming androstenedione. That becomes testosterone and dihydroxytestosterone. So what happens in a female fetus? Yeah, what happens in a female fetus? It causes female pseudo-hermaphroditism. What happens in a male fetus? Male fetus is getting exposed to androgen in excess. So it causes male precocious pseudo-puberty. Okay, and in this case the excess cholesterol is also diverted to form high 11-deoxycorticosterone. It forms high 11-deoxycorticosterone, and this 11-deoxycorticosterone has got mineralocorticoid activity. And this mineralocorticoid will cause excess sodium reabsorption and water reabsorption that causes hypertension. Yeah, that causes hypertension. So 11-beta hydroxylase defect. Do you remember I told you 11-beta hydroxylase defect will present as hypertensive form of congenital adrenal hyperplasia with female pseudo-hermaphroditism and male precocious pseudo-puberty. Okay. 11-deoxycorticosterone is there which has weak effect. Yes, 11-deoxycorticosterone is the mineralocorticoid which causes hypertension. Okay, so that's about 11-beta hydroxylase defect. Now the last enzyme defect is 17-alpha hydroxylase. Yeah, the last enzyme defect is 17-alpha hydroxylase. So all of you listen to this. When 17-alpha hydroxylase is defective, again what is not getting synthesized? Cortisol is not getting synthesized. No increase in aldosterone, Rahul. Because didn't I tell you 11-beta hydroxylase gene and aldosterone synthase gene are present closely on chromosome 8. I told you, right? Both these are present on chromosome 8 closely. And in almost all cases of 11-beta hydroxylase defect, aldosterone synthase is also defective. So both these are blocked. And that is why I told you hypertension in 11-beta hydroxylase defect is only because of high 11-deoxycorticosterone. Is that clear, Rahul? It is not because of aldosterone. It is because of high 11-deoxycorticosterone. Okay. So now we are discussing about 17-alpha hydroxylase defect. In 17-alpha hydroxylase defect, again I was telling you no cortisol. So that causes feedback stimulation of ACTH. So that again causes congenital adrenal hyperplasia. And the excess cholesterol in this case will be diverted towards forming what? In this case, the excess cholesterol will be diverted towards forming aldosterone, and that causes hypertension. Yeah, that causes hypertension. So 17-alpha hydroxylase defect will also present as hypertensive form of congenital adrenal hyperplasia. But in this case, do you understand that when there is a block in 17-alpha hydroxylase, there is no male sex hormone that is getting synthesized. Completely what is missing? Male sex hormones are missing. So what will happen in a male fetus? Any fetus by default will develop as a female. Do you all understand this? Any fetus by default will develop as a female. Only when the fetus is specified with an androgen there can be virilization. And in this fetus wherein there is 17-alpha hydroxylase deficiency, no androgen is getting synthesized. So no exposure to androgen. So the child will be born, the fetus will be born as a female. Okay, so it causes what? The child has got XY chromosome, but external genitalia and secondary sexual characteristics are of female type. So what will you call it as? You will call it as male pseudo-hermaphroditism. Yeah, what will you call it as? You will call it as male pseudo-hermaphroditism. This is why I have been repeatedly telling you the only congenital adrenal hyperplasia which presents as male pseudo-hermaphroditism is 17-alpha hydroxylase deficiency. And if your doubt is what if it's a female fetus, it will present as just hypogonadism. Yeah, if it's a female fetus, it will present as just hypogonadism. Okay. I answered that TS just now. Okay, so can we summarize about all congenital adrenal hyperplasias? Yeah, so what did I tell you about congenital adrenal hyperplasias? All of you remember this, there are two types. What are the two types of congenital adrenal hyperplasias? One is salt wasting form, the other one is hypertensive form. Okay, now what are the salt wasting forms, all of you? Salt wasting forms are two. One is 3-beta hydroxysteroid dehydrogenase defect. The other one is 21-beta hydroxylase defect. Okay, and how will you differentiate both the conditions I told you? Both will present as female pseudo-hermaphroditism. Very good. Both will present as female pseudo-hermaphroditism. To differentiate the two conditions, what is that we estimate? We estimate 17-hydroxyprogesterone. If 17-hydroxyprogesterone level is high, it is the most common 21-beta hydroxylase deficiency. If 17-hydroxyprogesterone level is low, it is relatively uncommon 3-beta hydroxysteroid dehydrogenase defect. Okay. Now about hypertensive forms. What are the two conditions which will present as hypertensive forms? One is 11-beta hydroxylase deficiency. The other one is 17-alpha hydroxylase deficiency. And between the two, which did I tell you will present as male pseudo-hermaphroditism? between the two, which will present as male pseudohermaphroditism, 17 alpha hydroxylase deficiency. Clear? So I hope you won't get confused anymore. So try to answer this. This is the last question for today's session. A 25-year-old woman seeks your help because she has a menstruation problem. She is short. When she was 13 years old, she had problem with excessive facial hair, and at age 14, she underwent surgical modifications to correct an enlarged clitoris. So what kind of pseudohermaphroditism is this, all of you? It is female pseudohermaphroditism. The moment you see it as female pseudohermaphroditism, of these choices, can you name one choice which can be excluded? What did I tell you? The only congenital adrenal hyperplasia which presents as male pseudohermaphroditism is 17 alpha hydroxylase deficiency. So this can be excluded, yeah, just because it is female pseudohermaphroditism. And the next statement says her blood pressure is low. Yeah, so it is salt wasting form. If it is salt wasting form, which condition can you exclude? There is a hypertensive form here, which is 11 beta hydroxylase deficiency, that can be excluded. So you are left with 21 beta and 3 beta hydroxysteroid dehydrogenase defect. Pelvic examination indicates she has a normal uterus. Laboratory examination indicates low sodium, yeah, so low cortisol. Plasma androstenedione is elevated. DHEAS is elevated. Plasma levels of 17 alpha hydroxyprogesterone level is low. So what did I tell you about this? In 21 beta hydroxylase defect, or the most common type of congenital adrenal hyperplasia, 17 alpha hydroxyprogesterone level will be high. So this is also excluded. So what are you left with, all of you? Very good, tireless. Good, all of you. What is the answer? The answer is 3 beta hydroxysteroid dehydrogenase defect. Is that clear? Yeah. So that is all about congenital adrenal hyperplasias. So if you are given a history which makes you suspect a congenital adrenal hyperplasia, just look at whether it is female pseudohermaphroditism or male pseudohermaphroditism. If it is male pseudohermaphroditism, close your eyes and mark it as 17 alpha hydroxylase deficiency. Okay, and if it is female pseudohermaphroditism, try to check whether it is a salt wasting form, yeah, whether it is a salt wasting form or is it a hypertensive form. And if it is hypertensive form with female pseudohermaphroditism, then that is 11 beta hydroxylase deficiency. Okay. If it is salt wasting form, you should have two things in mind. What are the two conditions which can present a salt wasting form? The most common type, which is 21 beta hydroxylase deficiency, and the other one is 3 beta hydroxysteroid dehydrogenase deficiency. And how will you differentiate these two conditions? By estimating 17 hydroxyprogesterone. If 17 hydroxyprogesterone levels are high, it is 21 beta hydroxylase deficiency. If that is low, then that is 3 beta hydroxysteroid dehydrogenase deficiency. So this is the mental algorithm that you can have to make a diagnosis of any congenital adrenal hyperplasia. So Rahul has got a doubt. What is your doubt? How is plasma androstenedione? What is the reason for normal blood pressure? So when it is a hypertensive form, as you know, blood pressure is maintained by multiple factors, right? So in a young child, hypertension does not present. It takes some time for the hypertension to present, for all the other factors to fail to maintain normal blood pressure. So all hypertensive forms do not present with hypertension at the time of birth or during early childhood. It takes some time. Okay. So what is your doubt, Rahul? How is androstenedione elevated? Yeah, good question. Okay, I think it's 200. Yeah, it is 200. It is low. Okay. So thank you all. Get the PDF from the group. Try to revise it. See you all tomorrow. Tomorrow I will be discussing about parathyroid. Yeah, so I'll be telling you about calcium phosphorus balance. I will be telling you about vitamin D, parathyroid, what is pseudo hypoparathyroidism, what is pseudo hypoparathyroidism, what are the features of hyperparathyroidism. Okay. Thank you. See you all. Good night.